Today's my topic is on the pulmonary case, and as you know, in the EDIC 2 exam, that is not very much discussion about the depth of theory, but they want to know how will you approach and what is your practical skill to make the patient is safe, because they consider this EDIC to pass candidate will be as a senior register in their ICU. They can manage at night if there is any emergency. So that is the concept of EDIC 2 exam. So the examiner try to understand your clinical skill. Yes, knowledge, of course, but depth of the knowledge they judge by part one exam, and in part two, the protocol and how smart you are to tackle the emergency situation. So now start with the case. Usually in your exam you will get four case uh, and, uh, and different scenario. Uh, There is a guideline that you will get one case on the post-surgical, one case in a respiratory where you will have the extracorporeal support. Another one case is related to cardiac where you may need extracorporeal support. And other case maybe it is obstructive or it may be due to in neuro is like that. But three case you will get definitely one from the post-surgical. Maybe it is due trauma or any surgery. Whether it is a aortic surgery. The like last time it was a patient, and in my time it was a poor intestinal obstruction. So whatever case you might get one surgical and three medical case. Uh, Now, Vinient, the first Vinient, Mr. Anisha, 30-year-old female, presented emergency department with complaint of respiratory distress, fever, cough for 3-4 days. GCS is full means 15 by 15, conscious, cooperative, little tachypneic, and pulse rate little. It's 100 BP is more than BP is nearly 100 by 60, and on auscultation, right-sided cackle is there. Patient was put on oxygen support, and critical care team asked for review, and this patient having no comorbidity. This is your scenario. Now, from this scenario, you're understanding that there is a case of respiratory tract infection and young patient with no comorbidity. This is the chest X-ray of this patient. You're seeing that there is a right lower jaw pneumonia, the CT. Now the question will be like that, what will be your provisional diagnosis? So I think you can use chat box because it is an interactive session. So what will be your provisional diagnosis here? You can unmute your you also. So
Sir,
yes,
community acquired pneumonia, sir.
yes, you are rightly said it is a community acquired pneumonia. And then next question, what will be your differential diagnosis? So, any differential diagnosis?
Polar aspiration
So remember, in this exam, the main tricky is the time. So you have to be very conscious about your time. And the second important thing is there is a no negative marking, only positive marking where you will be right. So they will put right marks. Or where if you miss something, they will put zero on. Okay. So you are try to give as maximum possibility answer here. Okay. So community acquired pneumonia is absolutely okay, but you can say this is a TI, the right-sided lower pneumonia. It may be aspiration, maybe because it is a light lower side. So the right answer is a community acquired pneumonia, but you can utter these are the thing also. So now coming to the initial management, how will you approach this patient? So anyone can tell
As usual, we start from airway breathing and circulation. This is mainstay of the treatment. After
yes,
that, then we have to assess the patient by CURB 65 or we have to assess by PCI or
very good,
by
very good.
another
Very good,
severity.
Vasirab. Then, okay. So you have to ask the initial management. Initial management means what are the things you will do in the emergency? One is the approach will be ABC, airway, breathing, circulation. Airway is patent. GCS is 15 by 15. The breathing is patient is tachypneic but need a little bit oxygen, and the circulation and the blood pressure is okay. Then you have to you may ask what are the monitoring you will do, what are the investigation you will send, what is your further plan of management. So that means the you have to ask for the investigation. What are the investigation you will send? Usually, we do send the complete blood count, urea, creatinine, AVG. We ask for the AVG, chest X-ray, CT scan already produced, but you have to ask the chest X-ray and CT scan already produced. Otherwise, we will ask for the chest X-ray and uh, first you will utter the chest X-ray, not CT. Okay, this is the report of this patient. Hemoglobin 10, TLC 18,000, platelet 1.2, SGOT, SGPT is marginally high, and LFT also. The urea is 63, creatinine 1.3. So patient was shifted to ICU. Now here might they ask the question, what are the your prognosticate marker? Okay. So I will come later on the question. So patient we have shifted to ICU. We have put in HFNC and X-ray CT already. You have seen the started IV antibiotic and patient so improvement. Next report is. So now your question here, what are the common organism which is the causative agent for your CAP? So tell me the anyone can yeah.
Streptococcal infection, Haemophilus influenza, Staphylococcus infection, and Moraxella infection. So I think these are the common.
Sir, viral, sir. Most common.
So you have to tell that the causative agent most common is Streptococcus pneumonia, and there is of typical, atypical, and the viral. Then you categorize the what are the typical bacteria, what are the atypical, and what are the virus. Then they will ask about the CT severity. So the commonest organism is a Streptococcus pneumonia, and typical bacteria Streptoneumoniae, Haemophilus, Moraxella, Staphylococcus. These are the list of bacteria for the typical, and these are the list of bacteria for atypical: Legionella, Chlamydia, and this Coxiella, and also virus. There are a lot of virus. Influenza is most common in the Asian country. So now, why this is typical and why that is atypical? What is the difference between typical and the atypical?
Apart from apart from signs and symptoms of pneumonia, they can cause atypical symptoms like diarrhea, rash, hyponatremia. There are so many things not related to pneumonia itself.
Uh, No, the most commonest point is atypical means there is a typical presentation like leukocytosis, fever, and it has a one lower pneumonia type of the most bacteria is doing the one-sided, but atypical means the presentation is atypical. If you see the influenza, it is bilateral. So I will request, please switch off your unmute, the mute your the mic. Otherwise, it is very noisy. So atypical means the presentation is atypical in terms of symptoms, in terms of signs. So symptom means this patient having fever, but there might not be a tachycardic. Second, this patient having infection, but there might be not the leukocyte count is high, not leukocytosis. So if you see the the Legionella infection or the viral infection, you will not get the WBC count is very high. So and also presented in the bilaterally. The virus is always bilateral, and your Legionella mycoplasma always produce bilateral pneumonia. That's why it is called atypical presentation, the atypical pneumonia. So next they will ask you about the scoring, how you will predicted the mortality of the patient, and what is your admission criteria from emergency to ICU or emergency to ward or emergency to OPD. How will you distinguish your patient by doing the SCOP 65? SCOP 65, the 65 is the age, more than 65, confusion, urea, respiratory rate, and systolic blood pressure. These are the parameter. If it is 0 to 1, you can treat outpatient basis. If 2, then inpatient ward basis. And if it is more than 3, then you have to admit this patient in the ICU. There are other scoring system also, like your
Smart COPS and
yeah,
PSI.
I'm coming. Just a minute. So the other scoring system is PCI scoring system, and carb 65 is also guide you the what antibiotic you will use for the treatment. Another very common common scoring is the PCI, where you have a demographic data, comorbidity, physical and vital sign, and the laboratory image. The PCI has a risk point 1, 2, 3, 4, 5, where the mortality, you can predict the mortality of the patient, and also you can do Apache and the severity of community acquired pneumonia. There is a two tools. One is the ASCAP, another SmartCov. I will come one by one. ASCAP is either one major criteria and the two minor criteria will make this patient is a severe community acquired pneumonia category. That is, one is the ABG, and other the major criteria, one is the ABG, and the pH, and the systolic blood pressure. And the minor criteria is the respiratory rate, PF ratio, blood urea nitrogen, alternate mental status, age, and multilobar bilateral on the radiography. SmartCov, which is very popular nowadays, for to check the severity. One is the S for systolic blood pressure, M for multilobar, A is the albumin, R respiratory rate, T is the tachycardia. And COP is C is confusion, O is oxygen saturation, and P is the pH. So it is a little bit more comprehensive, and 0 to 2 point in low risk for IRV, and 3 to 4 point moderate risks, 5 to 6 is the high risk, and 7 plus is the very high risk for ventilation and the mobility. Another criteria is your ATS criteria or IDSA criteria for diagnosis in a severe CAP and ICU admission. That is your one major criteria and three minor criteria. So major criteria here, septic shock, needing vasopression and respiratory failure, and the minor criteria. There is a list of minor criteria. I don't know why it is showing only two. So either again the same respiratory rate, pure ratio, then your urea nitrogen, altered sensorium, and all those things. Now, this patient we have did the HRCT is a large right-sided consolidation. ECG showing normal. Troponin I, it's a little raise is around 2. So on day 5, and the patient is okay. On day 5, there is a new onset of fever and increased oxygen requirement and rising total count 20,000. Fatma, please mute. Yeah, Fatma, be attentive. The drowsy GCS a little low, hypotensive, patient intubated, ventilated, and decreased urine output. This is the scenario. So at this point, how will you approach and cause of drowsiness? So now patient intubated and there is a infiltration, new infiltration fever. So it is a ventilator associated event. You may say it is ventilator associated event. At this period, you may ask question, what is the ventilator associated event? What are the common organism causing VAP? The scoring system of VAP, how to select antibiotic in new onset infection or VAP or HAP, and role of Procol in stewardship antibiotic investigation. If not improving, what investigation you will do, an antibiotic for CRE. So ventilator associated, now that is called VAE, ventilator associated condition. So after 2 days of stable decreasing PF and FiO, if the FiO2 increase, then you have to check the temperature, leukopenia or leukocytosis, or your uh, the 3-4 diagnostic criteria for diagnosis of the VAB, and you have to check whether it is a VAB or it is a VAT. Okay, take care it is. So what are the microbiological organism which cause the VAB? And the early onset pneumonia, again, Streptococcus pneumonia, Haemophilus influenza, Staphylococcus aureus, gram-negative bacilli, your escape bacteria, and the late onset VAP is a pathogen is more or less your MDR. But your question will be, if there is a new onset VAP, what antibiotic, if they said that what organism may be the commonest organism to causing VAP, so your answer will be as per our biological data. It is showing that my hospital has prevalence with either there are the four escape bacteria which is worldwide more prevalence. In Indian scenario, it is Klebsiella cre or Acinetobacter or E. coli and Pseudomonas is least. In Western country, it is MRSA, then ESBL, E. coli, and also Pseudomonas. So your answer will be in context of Asian country and the European country by seeing the IDSA guideline. If the IDSA has a good chart and between two continental, what will be the what are the causative organism, and the diagnostic criteria, again there is a CPI score for diagnosis of VAB, the tracheal secretion, the parameter is tracheal secretion, whether absent, purulent, or profuse, leukocytosis or leukopenia, temperature, PO2 FiO2 ratio, chest radiograph, new onset infiltration is there or not, and culture of the tracheal aspirate. So diagnostic accuracy, clinical pulmonary infection score, ventilator associated pneumonia, the meta-analysis showing that CPC score sensitivity is 64%, specificity is 64, sensitivity is 65, specificity is 64, and moderate diagnosis purpose, simple to use. And the investigation, what investigation you will do, the microbiological sampling, one is the important, and also biomarker like procalcitonin, C-reactive protein, and non-bronchoscopy. You can do mini bell, which commonly use, and it is accuracy is more or less same as bronchoscopy. And bronchoscopy guided aspiration is the gold standard. Protected specimen brass or the bell is a gold standard, and you can do the focus, which you will get idea about the P lines, new one, air bronchogram. These are the things you can identify in the focus, and biomarker already said, and in the bell biomarker you can do, these are the interleukin, but not very common, but we do the galactomannan test. Bell galactomannan is very sensitive. Sometime post influenza we found lot of fungal infection, and there is a newer biomarker endocan pentraxin 3, but it is not available in my institutes. Now then the question will be what empirical antibiotic you will start. If they ask about what will be your antibiotic choice, your answer will be that I will I will change antibiotic depending upon my local antibiogram. Why local antibiogram is important? Because in my ICU, the commonest organism is Klebsiella. So if the secondary HAP, or the secondary infection HAP or VAB, it is due to my own bugs. So I have to cover them. So it is depending upon the local antibiotic guidelines, or in a broad spectrum, you can cover any broad spectrum combination therapy. And in the Western country, it is commonest in the MRSA, where gram negative is common in India or in the Asian country. And you have to think about the risks of MDRO infection in VAB. So you might ask about the what are the risk factor for the MDRO. So there are some patient risk factor and some. So they might ask about the risk factor of MRSA, MRO. So next is the how long you will give the antibiotic treatment. They ask this question very often. The 7-day course for antimicrobial therapy in a simple case, but when you are in a MDRO scenario, then you have to continue for the 14 days. or if it is a fungal, then you have to do every 72 hours the culture sensitivity test. Once it is negative, then you can continue for another 14 days. So it is better you go for the IDSA guideline for antibiotic duration and the recommendation. So you will get this. Now they might ask about the VAB bundle. VAB bundle, what do you mean by VAB bundle, and component of the VAB bundle? VAB bundle is for reducing the VAB incidence in your ICU. Bundle contain head and bed elevation at least 30 degree, head side bed elevation, daily sedation interruption, peptic ulcer prophylaxis, deep vein prophylaxis, and thorough daily oral care and subglottic suction. This practice will reduce the incidence of VAB and incidence of the mortality. The basic mandatory measure and three highly recommended measure for the VAB bundle. One is the highly recommended measure is selective decontamination digestive tract oropharyngeal and continuous aspiration of the subglottic secretion and short course systemic antibiotic during intubation of patient on previous. But this is a old guideline and new guidelines are selective decontamination digestive tract has no mortality benefit. Only continuous aspiration subglottic secretion has a good mortality benefit, and there is a short course of systemic antibiotic has no role. Okay, but the basic mandatory things has shown that there is a improved mortality. So risk factor for MDR pathogen including Pseudomonas aeruginosa and other gram-negative bacilli and MRSA. One is the IV antibiotic use previously 90 days. This is a common guideline for every infection. You can, and we ask this question in the septic scenario also. So septic shock, ARDS preceding VAB, risk factor for the Pseudomonas if there is a structural lung disease colonization, and risk factor for MRSA when there is a colonization, and if the prevalence of the MRSA in the ICU or uh, there is isolate of MRSA in your ICU, and if there is a multiple lines in the patient. So now our patient have a severe metabolic acidosis and anemic for 6 hours. Patient already on the ventilator. Urea is 89 and creatinine is 2.8. Creatinine jump. Patient ventilator FiO2 is 100% and PEEP is 8. BP with noradrenaline support 100 by 68. So in this scenario, the examiner will ask you question like you can unmute for excuse me, you can unmute. The examiner will ask you question what next best treatment you will offer this patient. Anyone can unmute.
Roaming,
Yeah.
volume replacement, first trial.
Yes. So basically here the question will come from the your AKI part. So the examiner will ask you that what is the indication for dialysis, especially CRRT in European exam. In ICU, this type of scenario question means they are asking about the CRRT. Okay. So whether you will offer for CRRT or not, they want to ask, and what are the criteria for patient need early dialysis. They might ask about the VEXA score. What is VEXA scores and what is the important? Usually VEXA scores more important in fluid response to see the fluid responsiveness, whether the fluid is your patient might be a fluid responsive, but whether this patient having the fluid tolerance is there or not by checking your VEXA scores, or if you have the advanced hemodynamic monitoring, then the end extravascular lung water will guide you whether your patient is tolerant or not. So Bexar scores you have to remember how we will do and what is the significance. Next, they might ask about the indication of RRT, and indication of RRT, you might ask about the advantage disadvantage of the CRRT. And before appearing your EDIC 2 exam, you have to know the how to do prescription of the CRRT. I'm not going in details of prescription of the CRRT. I will take one class on CRRT before your exam because it is a very important topic, CRRT, and each and every student will get a scenario of CRRT, and you have to know all about. Okay. So then you might ask question about early versus late RRT initiation. Most of the question I have put it from previous examination. So these are the question already asked in your previous batch. So you might get similar type of question. So role of RAS idea, challenge test, management of this and the troubleshooting of the CRRT, it is very important. If the your CRRT machine giving alarm, what will you do? So why the machine is giving alarm, you have to identify. So now coming to my patient, that patient having FiO2 is 70%, PEEP10, noradrenaline support is there, patient continue deteriorate, and again, how will you approach? So, in this situation, you have to do echocardiogram, see the ejection fraction, volume status of the patient, and if the noradrenaline is you are giving in a maximum dose, it's not controlling the BP, then you have to go for the vasopression. The European said the early vasopression is a good for an aseptic patient. Oxygen requirement increase, difficult to ventilate. This is the X-ray of this patient. Intubated, central line is there. So this is the CT, second CT, where you can see the dense consolidation is going to ARDS. So next question will come from your ARDS. How will you approach? So it's might be a case on pulmonary edema, but patient on CRRT, so the chance of pulmonary edema is less, and the dense consolidation, the CT is showing that it is a ARDS. Now, when the scenario goes to ARDS, they will ask you question about the what Berlin criteria to diagnose ARDS, and not only Berlin criteria. They might ask about the what is the newer definition. In the newer definition, you know the same. The American College of Chest Physician has a new definition for the ARDS where instead of PO2 FiO2, they done the SPO2 and not PO2, the FiO2, SPO2 FiO2 ratio base. This is a wrong put of PO2 SPO2. It is not PO2 SPO2, it's SPO2 FiO2, because it has been shown that most of the resource country, even in India, the sub divisional area like district level hospital, in all the hospitals, especially in the nursing home, small town hospital, there is a no ABG machine. So how they will diagnose the case is ARDS. So that's why this American College of Chest Physician newer guideline, newer management of the ARDS. They have a criteria for diagnosis. You have to know all this criteria and the recommendation of this article. If you need, I can share it on your group. This article, please read before you going to a exam center. And you might ask about the role of steroid in ARDS and proning, how long you will do proning, what are the advantage, disadvantage of the proning, what is the physiological reason behind proning, and what are the trial is showing that proning is beneficial, and how long you will do proning. So ERDS diagnosis, supportive management, we already given. We have given 2 session of pronin, sedated, paralyzed my patient, but patient saturation is deteriorating. So here the question will come, uh, what will you do next? So that is, I will, if my patient on ARDS not responding on proning, then after second proning, I will ask for the ECMO team and I will start VV ECMO. There's recent ECLO guidelines saying that is come in the European Journal of Medicine also. If your patient not responder of the prone, then you can do early ECMO, where mortality benefit is definitely there. So when your scenario will enter in the ECMO, they will ask about the indication, Murare score, and how will you do cannulation, and what are the type of ECMO, then what do we mean by recirculation, troubleshooting, where what do you mean by recirculation, what is the management of pump failure. They will ask about different giving the different scenario and the different question on the ECMO, and how will you prognosticating in patient on ECMO, and if the patient is doing good, how will you recannulate and winning from the ECMO. So in my patient where the ECMO right lower limb is swollen and tense, so what will be the next approach? It is due to the ECMO has a bigger cannula, so there is a chance of distal perfusion defect. So you have to give another seed you have to put to make the perfusion, and prognosticate to family when this is a new things added, that communication part. So they will ask about the how will you do breaking bad news, how will you inform patient for question. That communication part has newly added in your exam scenario. There might be one question. So this patient 5 days ECMO ARDS is little bit settling, and start the noradrenaline has decreased. Put PCV day 2 after ECMO decannulation we have done. Now here the question will be, how will you do decannulation? Usually for venovenous ECMO will decannulate directly, and in a veno-arterial decannulation we need a support of the vascular surgeon, because this is the artery and we have to repair this artery. Next, you might get question about the winning for this particular case. The risk factor of ICU, acquired weakness, what are the measures to identify the delayed weakness, delayed winning, and protocol of the winning assessment, US winning induced cardiac dysfunction, percutaneous tracheostomy. These are the question you might get. And what I want to do, I have a one presentation on the ECMO, which is for examining. It is very important. So I'm just detailing the ECMO part. So there is a small presentation on ECMO, which I think it will help you a lot in your exam. Fatma, my hello, Fatma.
Yes, sir, your slides are visible.
Yeah. So ECMO is a extracorporeal membrane oxygenator, and it is a breach of therapy. It's when there is a probable potential reversible cause for the management, either it is due to heart failure or due to lung failure, you can use to bind the time. So this is a schematic diagram of the ECMO. This is basically cardiopulmonary bypass machine which is used in the OT, and the only difference between ECMO and the cardiopulmonary bypass machine is here is one pump, that is a centrifugal pump, and in a CBP machine it is a three roller pump is there. Otherwise it's a the principle is the same thing. It has two cannula. One is the drainage cannula and other is the return cannula. Drainage cannula is the blue in color. Return cannula is the red in color. So you have to your classification on the ECMO depending upon the cannulation. It is veno-arterial or veno-venous. Veno-venous one is the drainage cannula put it in the femoral vein, and return cannula either the opposite femoral or in the jugular vein. In veno-arterial, either same side, the femoral artery and the femoral vein, or the femoral means one-sided femoral vein and other-sided femoral artery, and the blood coming to your centrifugal pump, and from centrifugal pump to oxygenator, or it gas exchange done by gas coming from the blender where the oxygen and the air mixed gas come to the oxygenator, then the blood going to the heat exchanger. From in the heat exchanger, it gets the temperature, because it is a extracorporeal thing, blood coming from the vein, then it's entered the centrifugal pump, then in the oxygenator it loses the heat, and so heat is the heater, it improve it increase the temperature and maintain the 37 degrees Celsius to reduce the coagulopathy. Then blood goes to the circuit, the main in the body. So type of ECMO already mentioned, it is depending upon the cannulation, veno-venous, veno-arterial, or hybrid means veno-artery vein. We do the hybrid not very commonly, but we do in a regular fashion. When the suppose patient is ARDS and patient having cardiomyopathy also, then you need to give support to both the lungs and support to the heart. Then you need to have a veno-arterial things. I will come in a detailed pictorial. This is all about the indication is acute respiratory distress. The ARDS may be the cause may be direct or indirect injury in the lung. In a cardiomyopathy, and bridge to destination means the patient waiting for the lung transplant or cardiac transplant, and pediatric congenital cardiac disorder. So the important is the initiation of the ECMO. Initiation of ECMO is a priming of the machine and the cannulation. So priming of the machine is done by your is with a saline, normal saline and the heparin, and it is a team approach. This is the real time we are doing, like in our setup where the cannulation we do ourselves. Cannulation is not very big deal. It is just you are putting the center line is a similar way, only the diameter is a little bigger and the cannula is bigger, so you have to be little careful, otherwise you will do puncture on the wall. And priming usually done with a 9% saline, 0.9% saline with heparin, or you can do with the albumin and saline also. But nowadays blood albumin it is not very used, only saline and heparin is used. So these are the cannula. Arterial cannula is smaller size, venous cannula is a bigger size, and the distal perfusion, which in my patient have happened, the distal perfusion defect, because of this is a bigger cannula, it reduces the flow, arterial flow to the distal end, or venous congestion maybe sometime happens. So when there is a distal perfusion is problem, we put the seed for distal cannulation, distal perfusion. So this is a veno-arterial in the same limb, both femoral artery and the vein. We have put it the line, and this is the distal cannulation seat. So can how will you check the cannula position? By checking the X-ray, radiograph, or echocardiography. By radiography, you can see the upper one and lower one, and you have to maintain at least 10 centimeter gap, otherwise there will be a recirculation. So if you are not comfortable with the radiology, you can do the T to identify the position of your ECMO. This is the T. You can identify the position of the cannula. And next question on the the anticoagulant. Which anticoagulant you will use, and why anticoagulant is needed? Anticoagulant needed because it is a extracorporeal circuit, and you are inducing the coagulation cascade. For that's why you have to maintain the bleeding and the clotting risks. So clot-free ECMO run is myth, but sometime you have to accept that you are not able to give any anticoagulant to your patient. So what will you do? So that time what we do, the we increase the flow. So if you increase the flow, there is a chance of clotting is less. So you have to increase the RAM of the centrifugal machine to increase the flow, and you have to maintain the well hydration of the patient to reduce the viscosity of the blood. Otherwise, if there is no contraindication, you give heparin 50 unit per kg bolus during cannulation. Once the cannula is established, and then you can continue heparin uh, is 18 to 20 unit per kg, and your guide is the ACT, and the bedside ACT, you maintain ACT 140 to 200. You can use other anticoagulant like thrombin inhibitor, low molecular weight heparin, but I have never used. I use the heparin only. But the literature suggests you can do the anti-10 inhibitor also in a situation, special situation like heat. And ECMO monitoring, it is very important. The troubleshooting question you will face in ECMO. One is the color changes. The first thing monitoring, you have to monitor the color. The drainage cannula always with the black desaturated blood, and return cannula always will be the bright red. Then everything is perfect. If the both the cannula is black, so your the oxygenator life has gone. So you have to change the oxygenator. If the both the cannula is bright red, then there is a recirculation is happening. So you have to check the position of the your cannula. And other is coagulopathy, bleeding. You have to check according to, you have to monitor the ACT, adjust the dose of heparin, and do a take, check the what parameter is problem. And another problem is the flow disturbance. Flow disturbance is the console monitor for the ECMO, where you can directly identify by seeing the zigzag pattern, ECG pattern of the flow. Otherwise, normally it is a linear pattern like your fine VF or like a straight line. So if there is a flow disturbance is there, you have to check whether there is a circuit kinking is there or not, or the volume status of the patient, or your ramp is very high or not. So you have to reduce RAM, you have to maintain the hydration, and you have to check the kinking of the circuit if there is a flow disturbance. So when the ECMO is running, so what are the monitoring? The most important monitoring one is the coagulation, that is by ACT, and also you are doing other monitoring. Also, you have to check uh, the DO2 and the ABG PO2. So checking the tissue oxygenation level. And next is the advantage, disadvantage of ECMO is advantage of the ECMO is all, yes, it is when it is required, it is. And the disadvantage, it's needed lot of staff, specialization, perfusionist. And in your ECMO they might ask about the pump, centrifugal pump. Why centrifugal pump? Centrifugal pump has a very less hemolysis, and they might ask about the principle of centrifugal pump. So you have to be ready. Mobilization is important, cornerstone of the mobilization of patient. They might ask, this patient need uh, CT scan, how will you do? So mobilization is not a big deal. Only thing is that you have to have a good team. We do regular mobilize to our patient to for different purpose, for the CT, for physiotherapy, and for CT scan, for OT. This is 1971 ECMO, and this is 23. So now the world is going towards the portable ECMO. Thank you. Thank you guys for all about your CCS today. And I will take tomorrow class on CBS, where I will discuss about the images, X-rays, ECGs, lab values, and loop and curve. So the same time tomorrow at 3 p.m. Yeah, 4 p.m. I will try. 4 p.m. will be better. So tomorrow 4 p.m. again we will meet. Fatma, I
Yes, sir.
think there will be no problem to take class on 4 p.m. tomorrow
So 4 p.m. I'll let you know. Actually, we do have a session tomorrow at 4.
at 4.
Yeah.
Then if I'm free, then tomorrow is the CBS, and yeah, I will not take much time. So tomorrow you can give 3 p.m., but I have to check my schedule tomorrow.
Sure, sir.
Okay.
I'll contact you regarding that.
Thank you, guys. How many of you are giving exam this year in the May? You can unmute yourself and you can tell me.
Yes, sir, myself.
Okay. Dr. Durga and others.
Me also, sir.
Okay. So Fatima, you take you do a group where those are examining batch, those who are giving exam in this May only. So if they need any suggested topic for discussion, I'm available every day.
Sure, sir.
Okay.
Sure, sir. I will let
Ah.
you.
So the guys for this next 20 days is very crucial day for you. So please read in that way that your real patient, like usually how my patient goes and how I treat my patient. Usually the question come in that particular way. Uh, so you develop some question yourself, keeping in mind that guidelines, recommendation, principle, and the dosing. Like in the CRRT, I will take one class on the CRRT. CRRT again, what is the indication? How will you start? What is the troubleshooting? How will you prescribe CRRT dose? What is the dose and how will you calculate? And troubleshooting means what alarm, when the CRRT giving alarm, what alarm and how will you resolve the problem? So in that manner you do, and in a CVS you will get very less time, 10 minutes each, 10 minutes for each station. There is three station. So lab diagnosis where you will get problems, and the you have to diagnose the problem, and the you have to utter the management solution. So sometimes the question only for the diagnosis. So it is the lab diagnosis is really, because STEM is very big. So you have to remember all these things, and you have to utter the correct answer. This is a little tough. Sometimes it is not, because if you read the stem of the question, you will have the idea what exactly the problem is asking. Similarly, curve and loop is a straightforward. If you know, you can answer. Similarly, is in the image also, but read carefully the question stem, the main answer behind the stem of the question. Okay, thank you.
Thank you, everyone.